Good afternoon, everybody. Today we shall deal with genital tract fistulae. To define the genital tract fistulae are abnormal epithelialized communication tracts between genital tract and the urinary tract or alimentary tract or both urinary tract and alimentary tract. Types of genital tract fistula are fecal fistula and urinary fistula. Fecal fistula means the patient will complain of passing fetus through the fistula. And urinary fistula means the patient will have involuntary passage of urine. Fecal fistula. There are various causes due to it may be tubo-intestinal, connection between fallopian tube and the intestine, utero-intestinal, communication between the uterus and intestine. This generally occurs when we do medical termination of pregnancy or passing sound or dilators. When we pass, it may perforate the uterus and injure the intestine and may cause utero-intestinal fistulas and vagino-intestinal fistulas, or it is called recto-vaginal fistulas. Urinary fistulas may be ureteric, vesical, or urethrovaginal fistulas. The ureteric fistulas are ureterovaginal, uretero-abdominal. It is the connection, abnormal tract between the ureter and the vagina, or abnormal tract between the ureter and abdomen. The vesical fistulas are vesicovaginal. This is the commonest type of fistula, and vesicocervical, vesicouterine, and vesicoabdominal, and vesicointestinal. These may be connected with the vesicles, either vesicovaginal, vesicocervical, vesicouterine, vesicoabdominal, or vesicointestinal. And urethrovaginal fistula. There is a communication between a urethra and vagina. Vesicovaginal fistula or VVF. This is a communication between the bladder and the vagina, and the urine escapes into the vagina, causing true incontinence. The VVF causes true incontinence, whereas other urinary fistulas, they are called false incontinence. False incontinence. So, the fistulas, urinary fistulas are mainly divided into true incontinence and false incontinence. True incontinence occurs in vesicovaginal fistulas. And whereas false incontinence like stress incontinence, urge incontinence, nocturnal incontinence, overflow incontinence, they are all come under false incontinences. And this is the commonest type of genitourinary fistula. Here is in this picture, bladder. This is a small opening, vesicovaginal fistula in the cervix. This is just a cervical fistula. Vesicovaginal fistula is called VVF, and this is just a cervical, very close to the cervix. These are the varieties of genital fistula. First is urethrovaginal fistula. This is the communication between the urethra and vagina. This is the urethra and vagina. First is this is a urethrovaginal fistula. Second one is vesicovaginal fistula. This is the communication between the bladder and the vagina. And the third one is vesicocervical fistula. This is the third one, where is the communication between the bladder and the cervix. And ureterovaginal fistula. This is a communication between the ureter and vagina. This is ureterovaginal fistula. And rectovaginal fistula. This is the communication between the rectum and vagina. This is the rectum and vagina. These are the various types of fistulas: ureterovaginal, vesicovaginal, vesicocervical, uterovaginal, and ureterovaginal and rectovaginal. These are the various types of abnormal communications or fistulae we can find. Types depend on the type of fistula. It may be juxtacervical, close to the cervix. The communication between the supratrigeminal region of the bladder and the vagina. That is called high fistula. And the mid-vaginal fistula is communication between the base of the bladder and the vagina. And juxta-urethral, the communication between the neck of the bladder and the vagina. Here, we have shown the internal urethral orifice and the fistula, the trigone of the bladder, the openings of the ureteric openings on both sides, and the center is the fistula. This is a cystoscopic view showing relation of vesicovaginal fistula to the bladder trigone. What are the various causes of fistulas? Obstetric causes. This is the ischemic causes. Due to the obstructed labor, the bladder gets compressed between the fetal head and the symphysis pubis, causing ischemic necrosis and later infection and sloughing and fistula. This is called ischemic. This is the pathology behind causation of the fistula, vesicovaginal fistula, and takes few days, that is 3 to 5 days following delivery, to produce such type of fistula. And this is ischemic causes, and other causes are traumatic causes. Instrumental vaginal delivery, such as gestative operations, or forceps, especially with keloids forceps. This type of traumatic fistula occur. Abdominal operations such as hysterectomy for rupture of uterus or C-section.
So, good morning, my dear students. So, today we are going to start a new experience. Of course, the online classes you are all now getting experienced in. But this is an experiment which we are carrying out today. Let us see how far it goes. So, today we are trying to show you virtual demonstration of clinical science. How this will be is first I will just narrate salient history points. What are the points to be stressed in the history? Then
Genital fistulas. Bacteria చెప్పాను ఇలా genital fistula. ఈ అబ్బాయి పేరేంటి? గిరీష్ ఎక్కడికి వెళ్ళిపోయాడు? So, coming to the traumatic causes, sorry for the interruption. And ischemic causes we have already dealt, and traumatic causes, instrumental vaginal deliveries such as destructive operation or forceps, especially with keloids, and abdominal operations such as hysterectomy for rupture of uterus or cesarean section, especially repeat cesarean section. Then other gynecological causes are operative injuries due to anticoagulopathy, abdominal hysterectomy, and malignancy, advanced carcinoma of the cervix, vagina and bladder cause fistulae by direct spray. Then the radiation, trauma, infection like vaginal tuberculosis, lymphogranuloma, venereum, etc. This will cause gynecological fistulas. And coming to the clinical features, patient profile. Usually, young primiparous with history of difficult labor or instrumental delivery in recent past. Symptom coming to the symptoms, the patient complains of continuous escape of urine per vagina. Patient has no urge to pass urine. However, if the fistula is small, the escape of urine occurs in certain positions only. Signs: vulval inspection, escape of watery discharge per vagina, of anatomic ammoniacal, ammoniacal smell is characteristic. Evidence of evidence of sodden and excoriation of the vulva skin, varying degree of perineal tear may be present. Then coming to the internal, these are all the external inspection findings. And coming to the internal examination, if fistula is big enough, its position, size, and tissue at the margins are to be noted. Coming to the speculum examination, the Sims speculum in Sims position is Nature's position, gives a good view of the anterior vaginal wall fistula. Size, while after seeing the fistula, we must note the size, site, single or multiple, and scarring and sepsis can also be identified. These are the points to be noted to assess the prognosis after surgery. Confirmation of diagnosis. We do a 3-swab test. 3 cotton swabs are placed in the vagina, one at the vault, one at the middle, and one just above the introitus. Methylene blue is instilled into the bladder through a rubber catheter, and the patient is asked to walk for 5 minutes. She is then asked to lie down, and the swabs are removed for inspection, one after the other. This is the picture showing we have put 3 swabs in vagina. One is at the vault, second one is in the middle, and outer swab is just into the introitus. Methylene blue is injected to come to a diagnosis where from the leak is. If it's a ureteric fistula, the topmost swab will become wet. It will not take any strain. If it's a vesicovaginal fistula, the middle swab will take stain, and if it's a urethrovaginal fistula, the lower swab will take the blue stain. This is called 3-swab test using methylene blue to diagnose as a ureteric fistula, vesicovaginal fistula, or ureteric fistula. The observations are uppermost swab soaked with urine but unstained with dye. The lower 2 swabs remain dry. Then it is the diagnosis, ureterovaginal fistula. Then the upper and lower swabs remain dry and unstained, but the middle swab stained with dye. This is vesicovaginal fistula. And the upper 2 swabs remain dry, but the lower swab stained with dye. This is urethrovaginal fistula. Coming to the summary in clinical diagnosis, big fistula, visible fistula, treat visible fistulous tract, obvious escape of urine, and tiny fistula, dye test in Nature's position, escape of bubbles of air when the patient coughs, and we can do 3-swab tests to confirm the diagnosis. Whenever there is confusion in diagnosis, we can go ahead with cystoscopy. Treatment of vesicovaginal fistula, then conservative treatment, continuous bladder drainage for 3 weeks to 3 months, and for recently formed fistula. The treatment varies for these two. Treatment, definitive surgery and local repair by flap splitting method is preferred surgery. Flap splitting means we'll excise the scar, then we reflect flaps of the bladder and the vagina. We'll separate the flaps, then we shall suture them. Time is ideal time, 3 to 6 months following delivery. And principles of surgery, perfect asepsis to be maintained, good exposure of the fistula, and excision of the scar tissue around the margins, mobilization of the bladder wall from the vagina, suturing the bladder wall without tension in 2 layers with 30 Y-grip. These are the pictures. In the first picture, we are given a circular incision around the fistulous opening to excise the scar. Then we'll reflect the flaps and separate both vaginal mucosa and the bladder. Then we'll suture the bladder in 2 layers. Then with 30 Vicryl, and then after suturing the bladder in the 2 layers, then we'll suture the vaginal mucosa. And coming to the postoperative follow-up, then the other operation is edge pairing operation, originally developed by Mariam Sims in 1852, used to repair fistula Sims portion, exposing fistula with Sims speculum, and after pairing the margin, sutured the fistula at 30 by. So here the scar is excised, then the end-to-end suturing is done without tension. This is a modification of vaginal operation, ureteric opening close to the margins to introduce ureteric catheter prior to the repair to prevent inclusion of ureteric opening in suture. So whenever the fistula is very close to the ureteric opening in the bladder, then you have to put a ureteric catheter to prevent the ureter to get entangled in suture. Then the involvement of the bladder neck, suprapubic or vaginal cystostomy, prior hands as temporary urinary diversion to keep the repair area free from wet. Then associate with the complete perineal tear or rectovaginal fistula to repair the VVF first, followed by repair of ఎవరో ఒకరు ఉండుంటాయి బాబు ఇక్కడ మాట్లాడేది మారిపోతుంది. If the fistula is big and the margin are formed by bone, use of skin or muscle graft, materials graft from the bulbospongiosal muscle may be helpful. Then, Lutko's partial colpoclysis. For simple post-cystectomy vesicovaginal fistula, vaginal epithelium all round the fistula's edges denuded, the edges freshened, and raw surface are approximated with rows of absorbable sutures. This is a Chasser-Moyer technique. Bladder and the vagina are widely separated by flap splitting method. Bladder and vagina are sutured separately in 2 layers. Avoid tension on the suture lines. Bladder and vaginal suture line should not overlap. Special post-operative care. The catheter should be kept for about 10 to 14 days before removal. Periodic clamping of the catheter is to be done to see any leak of urine into the vagina. After being satisfied that no urine leaks into the vagina, the catheter is to be removed. The patient is advised to pass urine frequently, say 2 hourly, following removal of the catheter. The interval is gradually increased. So this is a post-operative care, what we have to take after repair. Urinary antiseptics either given at random or approximate to the sensitivity report. Bladder wash with low-acrylamide, 1 in 10,000 once daily, beginning 48 hours after the operation. but not exceeding 30 ml at a time. Advice during discharge: to pass urine more frequently, to avoid intercourse for at least 3 months, to defer pregnancy for at least 3 years. If conception occurs, to report to the hospital and must have mandatory antenatal checkup and hospital delivery. The successful repair should have an abdominal delivery. So cesarean section has to be done with a successful repair of any vesicovaginal fistula. If repair fails, local repair should again be attempted only after 3 months. Principles in the management of gynecological VVF. Detected during operation, repeat repair immediately in 2 layers. So while doing surgery, gynecological surgery, if you find that the bladder is injured, immediately, if you diagnose, you repair in 2 layers and close the bladder with number 30 Vicryl. Detected in post-operative period, to put an indwelling catheter for about 10 to 14 days. If fails to repair, it is to be done within 3 to 6 months. The malignant or post-radiation fistula, any of the following may relieve the symptoms. Ileal bladder, that means implantation of ureter into the ileal loop. Then anterior exenteration, colpoclysis, and infective fistula, eradication of specific infection to be done first, followed by repair. Fecal fistula. These are the, as I said, tubointestinal fistula. Fistula tract between fallopian tube and the intestine causes the tuberculous pyosalpinx. It may rupture into the gut and may cause tubointestinal fistulas. And the patient complains of feculent discharge through the uterus may ensue. Ureterointestinal fistula. Fistula between the uterointestinal fistula. Fistula between the uterus and the colon, usually caused by malignancy of the bowel, diverticulitis, pelvic abscess, and tuberculosis. These are the causes of uterointestinal fistula, and the patient complains of discharge of flatus and feces through cervix and vagina. Rectovaginal fistula. Fistula between rectum and vagina. Causes are incomplete suturing of a complete perineum. Complete perineal tear. As you know, perineal tears are various types, first degree, second, third degrees. Whenever there is a complete tear, if the repair is not complete, suturing is incomplete, then the patient is likely to develop rectovaginal fistula after following perineopathy and during hysterectomy. Then malignancy of cervix, bowel and vagina will lead to rectovaginal fistula. And diverticulitis, rectal abscess, pelvic abscess, tuberculosis, lymphogranuloma, and following radiotherapy. And the rectovaginal fistula may be congenital, which is very, very, very rare. And the patient complains of incontinence of feces and flatus. This is a rectovaginal fistula. So there is a communication between the rectum and the vagina. The patient passes feces through vagina. Investigations are routine blood investigation, proctoscopy, sigmoidoscopy, radiopaque dye, enema. Pre-operative preparation. Bowel should be emptied with enema and vagina disinfected by douches, antiseptic douches, and neomycin to sterilize the bowel contents. Whenever we repair the bowel, it must be sterilized initially with neomycin, sulfaconidine, or chiroxam tablets given orally. Surgery depends on the cause of the position of the fistula. Small rectovaginal fistula above the intact perineal body, excision of the fistula tract and closure of the defect will survive the purpose. Large RVF with perineal defects convert the fistula into a complete perineal tear and repair it. Surgery, fistula due to carcinoma, exentration operation, and colostomy has to be done. Fistula following radiotherapy, colpoclysis has to be done. Coming to the urinary fistula, as I said in vesicovaginal fistula, fistula between urinary bladder and the vagina. This is the commonest, opens in the midline on the trigon. This is the vesicovaginal fistula. This is the tract communicating bladder and the vagina. Causes, as I said already, obstetrical injuries in developing countries, prolonged obstructed labor, forceps rotation of the fetal head during mobilization of the bladder in cesarean section, extension of lower segment insertion to the bladder in the delivery of deeply impacted head, bladder and ureter involvement during suturing of lower uterine segment. Ureters may be involved when uterine vessels are ligated. While ligating the uterine vessels, if you are very close to the ureters and away to the midline, you are likely to suture the ureter. Then a rupture of the uterus. Then during craniotomy and symphysiotomy, there is a destructive operation of the fetus. When we do this, we are likely to injure the bladder. Operative injuries in developing countries are DH during removal of broad ligament tumors during vaginal hysterectomy, the bladder during TH and laparoscopy with pelvic adhesions, the injuring the urethra during angiography and during sling operations. Causes crush injuries to the pelvis, carcinoma of the vagina, genitourinary tuberculosis, schistosomiasis, then following radiotherapy for cancer cervix. When we give radiotherapy for cancer cervix, it may cause either injury to the bladder or to the ureter. Congenital persistent urogenital sinus, which is very, very, very rare. Clinical features of vesicovaginal fistula: constant dribbling of urine from vagina, excoriation of the vagina, vulva, and perineum and thighs, depression and social outcasting. That means the women can't attend the social activities and she will have depression because of the ammoniacal smell whenever she goes into the society. Coming to the ureteric fistulas, obstruction, clamping or ligation or inclusion in suture during operative procedure, partial transection while doing surgery, and complete transection. And devascularization is stripping of ureter during malnutrition. The vascularity of the ureter is cut and it is likely to be necrosed and cause devascularization and necrosis of the part of the ureter, leading to fistula. Clinical features of ureteric fistula are obstructive, anuria with pain in flanks, tender enlarged kidneys. The transection, when ureter is transected, urinary leak into the peritoneal cavity, immediately stormy postoperative course with nausea and vomiting, abdominal distension and paralytic ileus, fever and leukocytosis, and devascularization, delayed urinary lag for 2 weeks after surgery. Clinical features of urethrovaginal fistula. Patient is incontinent and dry. Dribbles urine only during active maturation. Patient is continent and dry and she dribbles urine only during active maturation in urethrovaginal fistula. Examine the patient in Nature's position, that is in Sims position, because the air enters the bladder and bubbles through the fistula opening when the patient coughs. Whenever there is small fistula, we can make out by seeing a bubble at the fistula opening and asking the patient to cough. The investigations are routine tests, complete blood count, renal function tests, serum electrolytes, the urine for culture. Sonography of the kidney, ureter and bladder, and intravenous pyrography. Then cystoscopy and ureteric catheterization, biopsy from the edge of the fistula following cancer. Surgery for ureteric fistula, total obstruction following bilateral ureteric resection. If obstruction detected, early offending ligages, remove the ureters, stented. In case of patient transaction, cystoscopic catheterization and stenting of the ureters to be done. Surgery for ureteric fistulas, case of complete transaction, implant cut end of the ureter into the bladder, or Bori flap operation of ureteroneocystostomy. So from the bladder wall, we'll create a tube-like thing and we'll put the cut end of the ureter into the bladder flap, that is called Bori's flap operation. Then ureteric diversion into the colon and formation of ileal conduct. Surgery for ureterovaginal fistula, closed vaginally by layer suturing after wide dissection. Then, when urethra is restored, a new urethra can be created by turning in a U-shaped vaginal flap to form a tube. Vesicovaginal fistulas. Fistula between the bladder and the uterus. Rare is a very rare variety of fistula caused by cesarean section. Vesicovaginal fistula. Patient remains continent as cervical outflow and the urine prevented by sphincteric action of this. Menorrhea, cyclical hematuria with menstrual blood trickling through the fistula into the bladder. That is called the passing of blood in the urine. That is during menstrual cycles. That is called menorrhea. Joseph's syndrome, classical triad of vaginal urinary leakage, cyclical hematuria, and amenorrhea. These three constitute a triad that is called Joseph's syndrome. Vesicovaginal fistulas demonstrated by cystoscopy but not by cystoscopy. So abdominal repair we can do, or hysterectomy if the fistula is large. Prevention of fistula. Improvement in obstetric care, sharp dissection of the bladder during hysterectomy, and early recognition and appropriate repair of injuries immediately. Thank you. So if you have got any doubts, you can ask the questions. Hi, Kumar. Should questions are చెప్పు. If you got any questions, you can put in chat box. చెప్పు.